Thank you. And now there are, 33 folks on the call. So for the rest of the introductions, we'd actually love for you to put your name, your organization, and your favorite fall physical activity in the chat box. So if you could go ahead and do your name, organization, and your favorite fall physical activity in the chat box, we can look at that real quick. And when we go to breakout sessions later, obviously you can introduce yourself to your group a little more closely. So everyone can put that info in for a minute here and then we'll move on. I love moderate to vigorous apple picking. That's fantastic. Forest biking, yes.
Abby doesn't mess with picking the apples. She just drinks the cider.
These are great. Great. Well, thank you everyone for joining us. Again, we're really excited. So the agenda today is really, we're going to provide a little bit of an overview of where we've been for the last 3 years. We, you all have helped us accomplish quite a bit in really getting the diabetes prevention program up and running here in Chicago. And we're really excited about the work you've all done and want to really celebrate the successes we've had so far. And we also want to talk a little bit about some of the current challenges we're seeing, as well as a new context with Medicaid coverage and such. And so we're going to give a little bit of an overview and presentation to start. And then for the final hour of the meeting, we're going to break into breakout groups. And you saw the assignment when Natrina sent the email out on Monday. We'll be in 4 different groups and we'll talk more about that later, but we'll really spend time today getting information from all of you about the strategic direction for year 4 of the grant, as well as potentially into year 5. So we're really looking forward to having your input today, and I'm going to turn it over to Rebecca to do a little bit of a review of where we've been. So go ahead, Rebecca.
Hi, everybody. So if you haven't been involved in the DPP expansion port strategy of our project, I'm just going to review this real quick, how we've gotten to where we are today. So in 2019, we put out an RFP and selected 8 organizations to fund. And so along with these 8 organizations, this CCH and SUHI provided DPP classes across Chicago for 2 years. And early this year, we launched another RFP, selected 2 more organizations to add to our Chicago Cares family. And in these 3 years, we've had about 500 participants in 80 cohorts across Chicago. And as you can see here, these are the organizations, the 12 organizations that we've worked with in these 3 years. So currently we are working with 10 organizations across Chicago. We have about 20 cohorts right now and 164 participants. During COVID, all classes were either paused or canceled or completely moved to a virtual setting. And currently there are classes that are trying to move over to either hybrid or in-person model. So on top of the DPP classes, lifestyle coaches really provide what fits under an umbrella of what we call program support to their participants. I want to go over just some things that coaches have provided, some support that coaches have provided their participants over the last 3 years. It's really amazing work that they've been doing. Coaches have served as like a referral source for mental health and medical appointments. Some coaches have even reached out to their participants on an individual basis, like calling them each participant of their classes one by one to assess on an individual basis any kind of services that they need. Coaches have brought behavioral health counselors, workout experts, like Zumba classes and yoga classes to their DPP classes. During COVID, coaches have really been the source for all COVID related information. And especially during COVID, they've amped up providing kind of healthy food boxes to their participants, even delivering them to each individual participant's home, things like that. So program supports have just been amazing and are really an important part of the DPP classes. So some challenges that have been, some challenges that already existed before COVID, but have especially been like highlighted during COVID, or new challenges like virtual, the transition to virtual classes, are things that we kind of want to touch on today and think about how we can work on these challenges. As you can see on the right-hand side of the screen, these are enrollment sources. This data was collected by our evaluators from surveys they provided to our Chicago Cares DPP participants. And you can see that healthcare professionals is the biggest enrollment source for our DPP classes, and media was just attributed to 1% of that. So we do want to look at what's been successful and how to maybe expand on what we've been successful in, and then look at maybe what hasn't been successful and how to best use our media and marketing strategy to make it more effective and work for us. Other challenges that have come up a lot is like staff turnover, which is like directly linked to retention in classes. And then of course, what's most important is this, these DPP classes are an extremely time intensive and demanding work that the funding is just doesn't reach all the need that there is. So we want to talk about that today too. So some systems that are being built that we're working on are, for example, the partnership between SUHI and Access Community Health Network. So Access is reviewing its EMR for pre-diabetic pre-diabetic patients, and they are sending letters to these patients and referring them to the SUHI DPP program. And then SUHI is gonna keep Access abreast on who enrolls and who completes the program with them. We're also working with CCH and First Mile Care are kind of exploring a partnership where First Mile Care would provide DPP classes to CCH's patient population. Alliance Chicago, who we've worked with since the beginning, is optimizing their support, EMR support for the Alliance Chicago DPP providers like Near North and Erie Family Health. And they're launching their second teleretina learning collaborative this month. We continue to work with HCS, providing a wonderful learning collaborative for our lifestyle coaches. And we also continue to work with Kivit, who's been providing branded materials and any kind of communication support for our DPP providers as well. Take it away, Jana.
Great, thank you, Rebecca. And then, so we wanted to sort of thinking about the next 2 years, we wanted to think about the new context we're working in. So I think most of you have seen, but as of August 1st, the Illinois Department of Healthcare and Family Services has put out a provider notice that Medicaid will now cover both the National Diabetes Prevention Program and Diabetes Self-Management and Education Support Services, which we're really excited about. And through our participation in the state's 1815 diabetes grant, we have started to put on some trainings for providers about how to enroll in Medicaid and how to submit claims for both of these services in Medicaid. There's actually the final of 3 trainings is tomorrow. And Kevin actually just helped us get those training recording links onto the Chicago Cares DPP website so that providers have access to those ongoing as well. But with Medicaid coverage, I think that changes some of the opportunities and really helps us think about maybe pivoting to something where we can really scale and build some of the systems in Chicago related to DPP. There's now, Medicare has paid, Medicaid it will now pay. And so really thinking about what happens to our DPP provider network after this grant is gone, how can we make it sustainable, and what systems do we really need to put in place so that providers can continue to offer the DPP cohorts in a sustainable way with all that they need, and help get members in, recruited, help deliver a high quality program, and then hopefully be able to bill a payer for reimbursement for their work. So I think it's an opportunity to shift Chicago Cares a little bit more to the systems building side to support providers in building these sustainable systems and partnerships across various groups. And we'll talk more about that in the breakout sessions. Just to note that also per the state's 1815 grant, the State Department of Public Health also applied for a grant from the National Association of Chronic Disease Directors that specifically focuses on Medicaid enrollment for DPP. And through that grant, the proposal is to provide up to 5 DPP providers with money and technical assistance and training to really get them up and running in the Medicaid system. So both enrolling in Medicaid, figuring out contracts and agreements with Medicaid health plans, doing the work necessary to recruit Medicaid eligible participants into the DPP program, and then making sure they have the internal systems necessary to move those folks through the billing and claims process and actually get reimbursement from Medicaid. So we know in order to actually move into Medicaid, there's a lot of internal systems that have to be built, especially since a lot of the programs are currently offered as a free service. So moving the patients through the free service into a billed service for those who already have billing and claim system is important. And then there's many DPP providers who don't have current billing and claim systems. So what kind of arrangements do they want and need if they want to seek reimbursement? So there are those activities that are coming through this state grant. Will cover a lot of folks outside of Chicago, but there are perhaps alignment opportunities here where we could use Chicago Cares funding to do something similar for Chicago-based providers. And not that Chicago-based providers are excluded from the state grant, but there might be opportunities to align the funding opportunities across geographies and create something similar. And I believe in that grant, there's also going to be some peer learning collaboratives or sort of peer communities of practice for people doing similar work to share and get some group TA and share their challenges in doing this work. So perhaps there could be some alignment between providers in Chicago and providers in other parts of the state. We also know that the virtual setting is becoming a more permanent option for DPP delivery. So thinking about what hybrid, virtual, distance learning, and in-person look like across the network and how we can support that further. And then Chicago Cares is obviously focused on Chicago, but there is this work going on across the state, and the State Health Department convened a stakeholder engagement group back in, I think, February of this year. Many of you may have participated, and there are follow-up working groups. There are 4 of those working groups thinking about increasing DPP availability across the state, increasing awareness about both prediabetes and the program for patients and providers, looking at how hub models might help support DPP providers in doing billing and claims. And also there's another group looking at coverage for other employers, private coverage, et cetera. And so there's all this work and momentum across the state. I definitely think there's opportunities to align with some of the conversations and make sure that in Chicago with this funding, we can really look at how can we make some of these systems work and potentially scale them in other parts of the state, or use what's working in other parts of the state and scale it here in Chicago. So I will say, thankfully, I've been participating in the IDPH work, and I can help see some connections there, but I'm really looking forward to gaining the momentum through all of these grant opportunities to really look at systems building in the years ahead. So I think next slide. So what we want to do today is have you help us decide how to invest the Chicago Cares funds in the best way possible to build these systems. So obviously there's funding. We have training providers, people who have offered training on from the ADCES Learning Collaborative for lifestyle coaches to training on Medicaid enrollment, technical assistance from the American Medical Association might be available. Like, how do we utilize our partners, our training technical assistance partners, as well as the funding to best move us forward towards a sustainable system? And we sent you all a logic model, which if for the first time seeing it might be, hopefully not today is not the first time you're seeing it. Hopefully you took a quick glance at it before today, but we did want to review this a little bit with you because I think where we really have been focusing on is, if you look, we've really been focusing on establishing DPP, which was really important. There was not a lot of DPP in Chicago, so we've really focused on that sort of green box on under the output internal provider systems. That first green box down was really about standing up DPP programs. We've been focusing a little bit on patient awareness and engagement, obviously advanced lifestyle coach training and quality improvement has really been a big part of what we've been doing. But as we move into a new world where Medicaid coverage works, we were thinking, if you look at the far right for the outcomes, our goal really now is to build a community-driven, high-quality, sustainable DPP program across Chicago, especially serving historically excluded communities and with a focus on Medicaid participants. We can certainly accept feedback on that outcome if anyone disagrees or wants something different there, but I think most of us have thought that, you know, we're looking for a sustainable system here in Chicago. And in order to build that, especially related to Medicaid, there are all of these different systems that have to be built and work together to get us to a place where we have this sort of sustainable connected network. And so that's what all these boxes are. And I'm not sure how much I need to go through any individual one of them, but our breakout sessions are going to be based on those black output boxes across the top. So we will have a group looking at internal provider systems. And for this, we're really thinking about both DPP providers, people providing the program, no matter if they're a healthcare provider or a community-based organization. What kind of things do they need to set up to expand DPP, bill Medicaid, et cetera? What do healthcare providers need to do internally to their systems? How do they raise awareness of DPP with their healthcare providers? How do they get more screening for prediabetes? How do they refer to DPP? How do they track their patient outcomes? Maybe there's health systems that have big data. Maybe they can pull that data to screen for eligibility and link those folks to DPP. Maybe somebody wants to try out the new quality improvement metrics that AMA has developed and set that up internally within their system. Maybe there's a systems-wide approach to billing and claims that people need support with, especially community-based organizations. So that work group will look through all of those boxes and think about that soon. But that's one area. The next is around patient and participant awareness and engagement. How do we let people know about the program? How do they find out if they have prediabetes? How do they get referrals is the other box, but I think referrals connects to this one too. How do they get referred to a program that really meets their needs? And how do we find out what their needs are? And then connectivity is really going to think about how this all connects. How do you move a patient from a healthcare provider into a DPP? How does a DPP provider refer to other services that person needs? How does data go back and forth between a Medicaid health plan and a provider? So all the connectivity and referral pieces will be another group. And then there will be a quality improvement group as well, really looking at how do we continuously improve the quality of DPP to impact both retention, recruitment, and success for participants. And so that will be a fourth group. So before we move on, I wanted to just pause, it's a lot of information, and see if there are any questions related to what we're doing today or this logic model, or any comments that anyone wanted to share before we move on. And feel free to put them in the chat box or unmute and say it out loud.
This is Matt O'Brien from Northwestern. Will we be focusing at all on the transition of programs to virtual delivery? Will there be any agenda items around that topic?
Yeah, you know, I think that can be integrated into a few places. So, I mean, really any of them. I think especially maybe in the quality improvement and internal provider system side, you certainly bring that up as you discuss it. And
Thanks.
there's for each of the, we'll talk about the breakout sessions more, but for each section, there's a missing pieces section. So that would definitely be a missing piece that was not reflected in this current logic model.
Sounds good. Thank you.
Mm-hmm.
So Jan, I have a, I don't know, community driven kind of jumps out at me for semi-obvious reasons. And for people who know me, they know why. You know, that unfortunately, especially with Medicaid, I mean, even with Medicare, I mean, on some level, and, you know, Stacy and Matt, you can kick me under the table. I mean, at some level, it can't be community driven, right? This is, you know, we're either doing a medical model or it's not. And I don't know. I mean, I sort of intellectually understand what you mean by community driven, and I certainly think you need stakeholder engagement, but I don't know if you're going to have a highly sustainable program if your first modifier is community driven, that this really needs to be, whether we're talking about integrated into public health system or integrated into, you know, healthcare, but that I think that needs to be in your vision if you're going to have highly sustainable.
Yeah, thanks, Janet. I think when we was thinking of it, we were thinking of something that is meeting community need, specific to that community. So something tailored to meet the needs of the specific population being served. But I do think that, you know, maybe moving that modifier to somewhere else in this outcome sentence would work better, perhaps, to put it where it's more around the meeting the needs as communities indicate. And I think Rebecca made a good point of these coaches are going above and beyond what DPP classes are and connecting folks to the things they need and to their local community partners. And so I think it's capturing that piece of it as a high quality, high touch program is what we had in mind when we put this in here. So, but I would be open to maybe moving where those words live, because it's not the whole system necessarily that's community driven. The building of a system is not community driven per se, but it's the delivery of the program and the additional supports provided by that program that I think would be community driven, perhaps.
I wonder if something like community responsive would be just a different words that would be
I like
more.
that.
Great, thank you. All right, any other questions about what we're doing or any thoughts on this logic model before we move on?
I'll just add, and since we have Kivit here for their expertise as well, how can we, you know, maybe it's a conversation throughout all of the threads. Maybe it's more to do with patient and healthcare provider engagement. I'm not sure, but how do we increase, this is built into what you're saying, but just the overall culture of awareness around screening. Because at the end of the day, the screen, you're not getting screened for pre-diabetes, you're getting screened for diabetes, and you may be classified into pre-diabetes. That's the awareness we're trying to build. And the reason I mentioned Kivit, since you're on, or Karen, since you're on representing Kivit, you know, any thoughts on how really good pervasive awareness is built around things like mammography? It's just sort of a normative cultural model for people seem to know that this is something they have to go get done. So how can we just increase overall awareness about diabetes screening in Chicago and sort of additional pathways? I know we've had this conversation, but additional thoughts that people have in our breakout groups.
Thank you. Yeah, and I think that we could go into a little bit of the instructions for the breakout group. So for each breakout group, you'll be talking about these inputs. So this is what we have control over here in the grant. So we have funding. We can connect and provide training, technical assistance, and communities of practice. Whoops. Maybe can you go back to the logic model? Sorry, Rebecca. And then the tailored communications will be a piece of all of the slides as well. So really think about how can communication support each of these things going forward. And so I think there's a communications component potentially to most of these boxes, if not all. So, all right, now go ahead, Rebecca, and go to the Jamboard. So pretty soon we will put you into this Jamboard. We'll send you the link so everyone can join. If you haven't already, it was in the email, but we'll put it in the chat box. You will spend the first 5 to 7 minutes in your group looking at your slide. So there's frame 2, 3, 4, and 5, and you'll pick the one that responds to your group. And your assignment again was, actually, do you know, Natrina, what the room number or what group numbers will be? I guess it does matter. I think people should know which group they're going to be in, but your facilitator will tell you what group you're in if you don't know when you get there. Each of the IPHI staff will serve as a facilitator, and you're going to spend the first 5 to 7 minutes individually filling in the frames with your own ideas. And to do that, over here on the left, there is this is a little sticky note you can create. There's a text box. You can write with a pen, although I don't think that's ideal in this situation, but I would prefer a sticky note or a text box. You would click, if you go to the next, oh, there you go. You can click a sticky note. You can pick a color if you like, type in your, type here, yep, and you click save and it'll show up on your board, and then you can move it to wherever you want. So you can see that if you go one more slide over, and the type will get smaller as you type more, so it won't all be gigantic. And so for each of these, again, for level of funding, you're going to answer 4 different questions. So you're going to individually do it and then come back together as a group for about 18, 20 minutes and have a group discussion about what was put on the board. And the questions you'll be considering are the following. What level and amount of funding is needed to support each activity in a meaningful way? So for example, if you're talking about, maybe we need a system-wide referral process where all DPP is connected to a common system. You would say, I think that should be funded at a system-wide approach rather than an individual provider by provider approach. And it would probably cost us at least $50,000 to come up with something meaningful, or it can be a range. What we're really looking for here is it no money needed and just training? Is there a little bit of money, like 5,000, 10,000 stipends just to get someone going? Or are we talking about big chunks of money here? Like this is going to be $200,000 to invest in something like this. So it doesn't have to be perfect amounts of money, but really ranges. And whether it's system-wide across the network, across Chicago, versus individual DPP provider gets 5,000, that individual DPP provider gets 5,000. You kind of do it provider by provider. So that's one question. That's the funding box. Then related to it, are there training, technical assistance, or community practice needs for that activity? So maybe people don't need funding, but they need a whole lot of technical assistance to figure out how to do something. And then we would write out what kind of technical assistance that you think they need. Are there tailored communications related to this activity? So maybe we want to create, as Dr. Patel said, some more awareness of just the fact that people should get screened for diabetes at a certain age, but that should be tailored to a specific population, or maybe we want it to be tailored to a specific provider group, building this into their quality measures. So you can kind of talk about that. And finally, this missing component, anything else that's missing in this category that you did not have, do not see in the logic model, new ideas that have popped up, new things we should think about, put them into that box. And then each group should select a spokesperson, because when we come back, we'll be coming back at 2:05. When you come back, we'll have each spokesperson spend a few minutes, very high level, what were some of the key things your group talked about that we should invest in. And after that, at the very end, we'll wrap up and we'll have a prioritization ranking process that we want to take. So we'll go ahead and go into breakout groups. We can put the Jamboard link into the chat box. Rebecca just did that. So you can click into the Jamboard. We'll go into your breakout rooms and we will come back at 2:05. So you have just over half an hour as a group to do this. So Natrina, let us know when we're ready for our groups. Thank you, everyone.
All right, sending everybody into their groups now.